Good afternoon. My name's Tim Markle, and this is Conversations on Showing Up for Kids, a feature of the Southern Regional Center where we talk to people that will have stuff that we want to know, basically. And we try to keep it casual and we try to keep it nice and fun and all that good stuff. So I am really glad that you all are here today, and we are recording this today. Today we will be talking with Sara Warner. Sara is with the Autism Treatment Program at the Waisman Center, as well as the Autism and Developmental Disabilities Clinic. She has weird letters after her name that you don't see a lot, PsyD. So the first thing we're going to do is we're going to introduce Sara and welcome Sara. And then I am going to ask her, what does PsyD mean? Because you don't see it. It's not as common as MD, PhD, all those other things. So first of all, Sara, welcome. And what's a PsyD?
Well, thank you, Tim. Thanks for having me here today. I'm really excited to be here talking with you all. And yes, what is a PsyD? That was a question I had too in the beginning of my autism, in my psychology training journey. So a PsyD is a doctorate specific in psychology. So a PhD is a doctor of philosophy, but it can be applied to pretty much any area of study, including psychology. But then there is a separate degree path that people can choose to take if they'd like to get a doctorate in the realm of psychology, and it's a PsyD. And so that's what it is.
So you get to hold your own in a room full of PhDs. You get to be right in there with them.
I try.
Absolutely. So Sara, I was able to catch your presentation at the Autism Day with the Experts in January. And as we get talking, I'll post a link to that because that's been recorded as well. But I have been working in the area of disabilities and also in the area of mental health for many, many years now. And I learned quite a few things. I love the stuff that is coming out around depression and autism. So can you just start us off with what normally we think of as depression? And what are some of the common signs that people say that, oh, I'm just so depressed? What sort of stuff goes with depression?
Yeah. So I think one of the most common signs or things that we hear is exactly what you just said, is we think about people saying statements like, I am so depressed, I am feeling sad, labeling those emotional experiences. If we're looking at kind of diagnostic criteria that we as kind of the medical community are looking for when thinking about if somebody meets criteria for what we consider depression, we're thinking about things like depressed mood, loss of pleasure in previous activities that we would have found pleasurable or enjoyable. It might look like changes in our energy level, so feeling more fatigued, having less energy, less ability to concentrate, feelings of worthlessness. At the extreme ends, we certainly can have suicidal ideation, suicidal thoughts, suicidal actions. And then there's also some more physical changes that we might experience or might express, such as changes in our sleep patterns or our eating habits. And so those are that kind of encompasses the major areas of what kind of the mental health and medical communities describe as depression or a depressive episode.
And it strikes me that you have those definitions, but a lot of it is very subjective.
Yes.
It's based on where I feel my baseline is, and then how it goes up and down. And when it goes down, I may say that I'm feeling depressed. And it seems to be a very individualized type rating.
Yes, absolutely. And I think that is one of the tricky places with potentially diagnosing depression in general, is that a lot of times we're not coming and seeking help or asking for more support until we've had a change from our baseline, and that we are experiencing some more of these feelings or experiences. But then oftentimes the provider, the person that we're going to, might not have known us prior to this. And so there's a lot of onus put on the person themselves to be able to communicate and express all of this information to the person that they're coming and seeking help from, during a time where for anybody, it's probably more difficult to be communicating and expressing some of these thoughts and feelings.
And that brings up one of the most interesting things to me about this intersection of depression and autism, is the fact that, I tend to know depression for whatever reasons. Read into that statement, whatever you want to read in the statement, it's probably true, whatever you want to read into the statement. So I know depression, I've struggled with that. And one of the things that has always helped me is trying to find the words to describe that.
Mm-hmm.
And so I think of like my son who has autism and how he sometimes struggles to find words to describe a lot of things,
Yes.
not just his feelings,
Mm-hmm.
but his thoughts, his reactions. Is sometimes the words don't come easy to him. And I know that there's a lot of people on the autism spectrum that struggle with verbal communication, is that verbal processing and then communication. And then we have that introspection
Mm-hmm.
that we're also talking about in describing that. And so I was really interested in learning about how people with autism, if we're not going to sit there and go, oh, I know you're depressed because you tell me about your depressive symptoms, because you have said, I am depressed, I feel depressed, I'm having a depressed day. If that's not going to happen, what sort of stuff can we look for in our friends, family who may be dealing with depression, but not able to express it?
Yeah, I think that's the most excellent question. And my very simplistic answer to it, and then I'll get into some more details as we go along, but is really looking for those observable changes. And I think this would be true, whether we're talking about autistic individuals, neurotypical individuals, or anywhere in between, is that like Tim, you were expressing before, and we were talking about, depression is a change from our baseline. So while autism as a diagnosis is understood as kind of part of our neurology, it's part of our neurodevelopment, how we were born and how we have continued to develop. Depression is something that we're not necessarily born with. Maybe we are born with a predisposition to it, but we're not born with the condition. And so it's something that develops. And so when we start to experience that area, when we experience depression, it's inherently a change from what our baseline is. And so my first answer, my first thought to that question, especially if you're somebody that has known a particular individual or person over time, is to look for observable changes in their behavior. Things that you can see or hear that is telling you that something is different. It may or may not be linked to depression, but if that's something that you're concerned about, that can be something that's kind of on your mind as you're thinking about what these different observable changes that you're seeing might be. Now, if I go a little bit deeper into it with, if we're saying that those on the autism spectrum, autistic individuals, may not be expressing depression in the same way that that others are, or that the medical community has defined as depression. And I also want to say that certainly there are autistic individuals out there that will express depression in maybe more of that prototypical way that we understand it to be. But certainly we know, as Tim, you had alluded to as well, that a lot of times that is not the case. And so really, again, what we're looking for is changes from baseline. And when I'm thinking about what depression symptoms might look like in those with autism, some things I'm really thinking about are changes in really what some of the criteria for autism are, which is interesting. So I'm going to kind of switch gears just slightly, and just to talk about the kind of the criteria, what I'm thinking about when I think about what autism is from a diagnostic standpoint. And really we're talking about differences in somebody's social communication patterns and having this presence of restricted and repetitive like behaviors. And then when we're applying that or thinking about, well, what might depression look like within that realm, some things that we might want to consider, we might want to think about are changes in how those criteria for autism are presenting themselves for that person. So it could mean a change in their areas of restricted interest to being, to potentially being less interested in certain areas. That might be a little bit more prototypical of that idea of losing pleasure in things we once found pleasurable. But the flip side could also be an indicator of depression, which is where this definitely gets kind of messy, and there's a gray zone there for sure, where we might see an increased intensity in those what we call circumscribed interests or more fixated areas of interest. We might see an increase in repetitive behavior patterns that person might be expressing. We might see more rigidity. So we know that autistic individuals might have more of a tendency towards more of that rigid or black and white thinking patterns. And so we might see an increase in those types of thinking patterns. We might see a higher level of aggression or self-injury if that is something that is applicable for that person. We might see regressive behavior. So we might see that that individuals might not be engaging in skills or behaviors that they once were. And kind of along those lines as well, we might see a decline in self-care or what we call like adaptive behaviors, daily living skills. And so these, I think, are more specific areas that we can think about when we're thinking about autistic individuals and depression. But even at the same time, as I'm kind of talking through these, I'm also thinking, well, these could also be observable signs that we might be able to see in individuals who don't have autism as well. But really, I think what we're talking about or thinking about here is we're flipping it from thinking about depression as an internal experience that person, where the responsibility is on that person to express that to others, and flipping it to thinking about what can we as the outside individuals do to understand what these behavior changes might be meaning. I'm going to stop there because I feel like I've been rambling now for quite some time.
No, you're doing great, because yeah, I mean, it strikes me, Sarah, that what we all have ups and downs during our days, right? And during our weeks and during our lives. But when but we usually operate within like this narrow band of I can deal with this. So I could deal with a little up and I can deal with a little down. But if it gets too up or too down, then I start to feel like I don't have the right tools to be able to deal with it. And that makes me anxious, and that makes me worried that I'm going to do something really wrong, because I don't feel like I'm in control when it's way low or way high. And so I really like the explanation that it's this observable change when someone's outside of what their normal operating is, whether that's to the high or the low. There's at least the opening to say, I want to dig a little deeper into this. I want to know a little bit more. I want to see if everything's okay with this person. And it could be they're just having a really fantastically great day. Or it could be that something really bad has happened in their life and they're very sad about it. But observing and then having that conversation instead of ignoring what could just look like, oh my gosh, what I've heard people say is, oh, they're just being really autistic today. Oh, it drives me nuts. And it's just like, if there's a change in the behavior, we can't write it off as, oh, their autism is acting up. That's not a thing. And so questioning, asking that person, what's going on? What's changed? What's going on? What are you feeling, as best as you can. So I really like the way you put that, talking about those increases and the decreases. So let's say that we get really good at being with watching and observing our friends and our family.
Mhm.
And we notice that there's been this change, and we talk to them, and sure enough, we might be dealing with a little bit of depression. Well, we know that, one of the things we do is we say, okay, well, get our antidepressants. You can get them at your local pharmacy. Doctors are handing them out like anything else. So, yep, everybody gets an antidepressant. You get an antidepressant. You get an antidepressant. Everybody gets an antidepressant. Or you go somewhere and you talk it through, talk it out. Cognitive behavioral therapy is learning, what is my mind saying? What are the words that I'm telling myself? What am I then acting upon those words? And then what's the result in the world around me? Those would be my two go-tos if somebody came to me. Are those effective with people on the spectrum, or are there other thoughts that are emerging as we look at this population?
Yeah, so I think that's a great next step for taking this conversation, because once we recognize that depression is present, then the question is, okay, well, what do we do about it? And I think in general, those are the two main treatment pathways. So we have we have medications or medication management. I'm going to be incredibly honest. I'm not going to spend too much time talking in that area. I'm not a medical doctor, so I don't have as much expertise or background in that area. If there's specific questions around, around antidepressants or medication, you can certainly feel free to throw them out here. Although I will forewarn you that my answer will likely be, I am not sure, or that is outside my realm of expertise, but we can certainly give it a try. But that certainly is a valid pathway for treatment, and certainly one that is used with autistic individuals. What I'm not sure about, or I don't have necessarily the information to back up any assertions one way or the other, is the effectiveness of pharmacological treatments, so medications, for those with autism, and how that might compare to those without autism, if there's measurable differences in their effectiveness one way or the other. I think that's a great question to be asking. I'm sure we have information from the medical community on that. I'm just not sure exactly what it is. But then the flip side,
I am not quite as confident as you, Sarah, that we have really looked into that research question.
That's true.
I would hope that it'd be out there somewhere,
being a
but
little overly optimistic about it.
Maybe just a little, but
a little bit.
Continue on. I should learn not to interrupt.
No, interrupt away. I get on rambling tangents, and I have a 2-year-old at home who doesn't like to sleep. So yeah, if at any point it sounds like I'm not making any sense to him, just interrupt and say, Sarah, no, you need to stop now. But the other pathway to treatment is therapy of some kind. And Tim, you mentioned CBT, or cognitive behavioral therapy. That's certainly a well talked about and well-researched area of therapy for depression, specifically in neurotypical individuals. So not necessarily nearly as much research in efficacy or effectiveness of those treatments for the autistic population. And so in general, those are our two pathways. But there are different, I think, with medication, there's certainly different types of antidepressants. With treatment, or with therapy, there's also different types of therapy. So cognitive behavioral therapy is only one type of therapy. It's a pretty big umbrella term, and there's a lot that falls underneath it. And certainly, again, for some people on the autism spectrum or not, that's going to be a helpful tool or pathway to go down. For others, it's not. It does rely heavily on that communication aspect, and putting a lot of that responsibility again on the individual to be able to communicate, recognize, I think first recognize, and then be able to put into words what they're recognizing, in order to express that to somebody else who can then potentially make helpful suggestions or comments about, what can we do next?
And that, for some people, they can do it, but it takes a heck of a lot of energy.
Yes.
It's just like totally drained afterwards. So that may not be the best, even.
Right.
even if all the skills are there, it
Mhm.
still may not be the best pathway.
Absolutely, absolutely. And so I think my number one thing to be thinking about if we're thinking about therapeutic interventions for autistic individuals who may also be experiencing depression is to be connecting with a provider who is familiar with autism. In that there are plenty of providers out there that work well with depression. But part of what we know and understand around autism is that those who are on the spectrum may be taking in, processing, understanding the information that's coming at them from the environment differently than how we might expect them to as neurotypical individuals, especially with the, maybe the well researched, but still lacking in some areas curriculum for treating depression. Most of these types of therapeutic approaches, again, have been developed based on neurotypical populations and on adults as well. So I know we haven't really been talking about the difference between children, adolescents, and adults with regards to this whole area. That's a whole other area, and I can certainly get into it maybe a little bit if we have time. We'll see. Sorry, I completely just threw myself off my train of thought there.
That's okay, because you put back in your mind that, okay, if I have time, I want to talk about the difference between children, adolescents, and adults, and treatment and presentation of depression. But then I was back on talking about the differences in therapies first, though.
Yes. Yes. Thank you, Tim. Yes. You got my train back on track. So I think there are a lot of curricula. There's a lot of therapeutic options out there for treating depression. And I don't think that we need to discount them just because they haven't been developed specifically for the autistic population. But I think in order for them to be as effective as possible for any individual, but for the autistic population, we really needed them to be well understood by the provider, as well as having the provider who understands autism well, to be able to understand, maybe what modifications or changes or adaptations might need to be made in order for that material or that information to be most effective and useful to the person they're treating. So there haven't necessarily been tons of research out there on, specific interventions that are specific just for the autistic population. So I think the tools that we're going to be pulling from most of the time are the well-established tools that are already out there related to depression. But it's about realizing and understanding what adaptations, what changes, what modifications might need to be made in order for this to be an effective tool for the person that they're working with. And so really, I think in order for that to happen, we need to have a provider who is well-versed in autism.
Which also then brings up the fact that, just like we have two neurotypical people, there's not really a baseline normal. There's not really a neurotypical person. There's not a autistic individual either. Is that
right?
That personality and the personal ways that our bodies, our minds, and our emotions interact with each other is very, it's mine. It's not yours, it's mine. And so that adaptation, it goes down to that personal level even. Do you have any examples or ideas of examples, I guess I should say, since how I know this isn't a well-developed area. So thoughts or examples on what these adaptations may look like?
Yeah, I mean, that's a great question. And I think it kind of goes back to what you were just saying, and that it is going to be pretty individual for each individual person. And I think one other point that I think is just important to make that kind of jumps back to what you were just saying, Tim, is that not every therapeutic approach is going to be the right fit for any one individual, neurotypical or not. And so I also think it's important to recognize that if a therapeutic approach isn't working, it may be that the way that the material or the information is being presented is not effective for that person due to their neurology or due to their neurodevelopment, such as having autism. But it also could be that this is just not a useful tool for that person in general, unrelated necessarily to the fact that they are on the autism spectrum or that they are autistic. And so I also always am cautious to not always jump to, oh, this isn't effective because autism is in the picture. There's certainly many other explanations or reasons for that. But I think, so getting back to your question though, Tim, I think there are some things that we can be thinking about. One thing I'm always thinking about is how is literally how is the information being presented? Is it just somebody talking to you? Is there any visual supports? Is there any, is there any supplements to the information so that it's not just like, okay, here it is, we're going to talk about it in this one therapy session, 1 hour, maybe once a week, if that's and that's kind of usually the highest frequency that a lot of people will engage in therapy for. But then how can we help take that information out of that 1 hour once a week session to be able to apply it to more widely to our everyday life? One thing could be, providing more visual supports, whether that's in the form of, written communications, pictures, whatever might work best for that person. It could be, again, depending on certainly the age and the comfort level of the person engaging in the therapy process. It could mean having a support person that comes to sessions with you, so that you have somebody else that can help kind of be a reference to what you're learning and what you're working on in the therapy sessions. I also just think about the language we use when we talk about depression or mental health, and thinking about using concrete, explicit terminology when language when we're talking about these things. I think it's often easy to talk in metaphorical or non-literal ways about feelings or experiences, or kind of what we can be doing to work through some of those things. And sometimes that's not going to be a clear route of communication for individuals on the spectrum. Although there are some initial thoughts there. I'll pause and see.
All right. Yep. And I'm going to pause because I've totally monopolized this conversation, and we have some very intelligent and wonderful people that have joined us today. And so I do want to take this moment to say, feel free if you would like to ask Sarah a question, further clarification or something she hasn't talked about quite yet. Feel free to unmute yourself and I'll be able to see that, and then I'll call on you, or you can put your questions in the chat and I'll be more than happy to relay them. So one of the things that, so as you are thinking about your questions, I'm going to ask one more to give you time to get your thoughts going. One of the things that I learned back in the day, one of the things that I read, and I still think this holds true today, is that one of the best indicators of outcome is the therapeutic relationship. And so going back to those providers, if we have a therapist or counselor that doesn't understand autism, that doesn't understand what could be slower processing, that doesn't understand the need for visual supports, that doesn't understand the need for repetition. My son just said to me today, I don't get it the first time. I'm like, whoa, that is highly insightful, dude, because that affects employment, that affects higher education. That just like blew me away.
Yeah, I love that, because that's not necessarily something I just mentioned, but the needing to potentially, go over the same material multiple times, and understanding that might be just part of that person's processing and understanding, and not necessarily a signal of lack of engagement. Right. Or lack of, I'm not, yeah. Oh, I love that. I love that. Yeah. Lack of, oh, you don't really seem to care. It's like, no, I'm thinking about this. This is hard stuff. Yes. And so having that therapist who is okay with neurodiversity is so vital, because if it's not there, then
it's inevitable. There's going to be a clash because then there's going to be expectations, as you keep saying, from the therapist that are put onto the person.
Mhm.
And we can handle so many expectations, but what if they're overwhelming expectations? And so that's just going to lead to this conflict, and that's going to hurt the therapeutic relationship, which is vital to being able to successfully get better, to be healthier. So I gave you all enough time. Any questions that are out there, please. We would love to have you chime in. Signe, do you have a question?
I do, Tim. Thank you. I was wondering, and I'm sorry I missed most of the presentation, if not all. I apologize. But I was wondering, is there any, I guess, any evidence that depression shows up differently for autistic folks, and what are the signals that we should look for?
Yeah, that's an excellent question. So I think my number one response to that is thinking about depression as kind of this idea of it being a change from baseline. So that it's something is different, something has changed, and now we need to kind of investigate and explore what might be leading to that change. What we find for autistic individuals is that what we might actually be seeing is a change in the intensity or the frequency of what we might understand to be autism related behaviors. So repetitive behaviors, how somebody is socially engaging, socially communicating, restricted areas of interest where we might see either an intensity in an increase in intensity in those areas, or a decrease in interest in those areas. And so I think for a lot of times when we're thinking about autism or depression and autism, we're thinking about what changes in observable behavior can we see, because a lot of times, and what we understand depression to be is it's based on very internal experiences that most of the time others can't see. Some maybe, like changes in sleep, changes in our eating patterns. If we live with other people, if there's people that can, that are around us a lot, might be able to pick up on some of those changes. But a lot of what we understand depression to be is about internal experiences. So with autism, we're wanting to flip that and look at what can we see and hear that can indicate that some change has taken place that we need to be aware of.
Thank you. Any other questions that are out there? Thanks for asking the question, Signe. I appreciate that. Peggy? Or
Yeah,
let's go Peggy and then Josh.
Yep, this is Peggy Helmquist, and I just won't put my camera on because my internet is really goofy.
That is okay.
But anyway, the question I have is, sometimes persons with autism, because of their autism, I guess I'll say in and of itself, lends more to them to sometimes call it echolalia, but they might do it in a behavioral type of a sense. So if somebody in their family or a neighbor or somebody says, oh, I have depression, or I have this, or I have that, the person may then themselves say, oh, that's me, and that's what I've got, or that's kind of, they kind of may mimic that. I don't want to really say it's mimicking in a way, because, I'm looking at very intelligent persons on the autism spectrum, yet at the same time may exhibit these kind of behaviors because others around them also have those behaviors.
Mm-hmm. Yeah, I think, oh, sorry, am I interrupting you?
No, that was it.
Yes, I think that's a really great point. And I think part of why we need to, have thorough exploration of what these changes may mean, because the answer is not always going to be depression, certainly. There are certainly other mental health areas where I would be saying similar information, if we're talking about anxiety or other mental health concerns where, I might have this more simplistic answer at first of, well, let's look at what's different and let's come up with a hypothesis or a reason why we might be seeing these differences. And so that's where, again, I think from kind of the standpoint of trying to recognize what some of these changes might mean, similar to what I was saying with therapeutic interventions, we need to be the best we can working with providers that have some level of understanding of autism and can start to kind of tease some of these areas apart, because it is tricky and it's not black and white, and there's more gray than there is anything else. And I know I didn't necessarily talk about this during this talk, but I think one of the other things that makes recognizing depression in autism more difficult or trickier at times is that we, as a medical community or psychiatric community, we have tried to establish assessment tools that we can use to understand if somebody is truly experiencing depression. But again, most of these tools rely on self-report and are based on those prototypical definitions of what depression is. So they're only as good as who's using them and how we're understanding those answers. So.
Excellent. Mr. Davidson, sir.
Hey, Tim and Sarah, thank you for your time. You've talked about a couple times now finding mental health practitioners that have experience working with neurodiverse populations. And Tim, this might be a question for you. I know you like your resources and lists. I'm wondering if you have lists of providers who have experience working with this group of people, at least in the Dane County area.
Oh my. The quick answer is not really. We are constantly trying to build that list at the Southern Regional Center to try to determine who is it that we could trustworthily, I guess, not a word, trustworthily say that, yes, this is someone who gets autism and is a qualified mental health provider. There are mental health providers out there that will say, yeah, they understand autism, but I wouldn't necessarily agree with them. So, do I wish we had some sort of ribbon, banner, notification, certification that there was a certain level of competency and expertise and knowledge around autism and mental health for some mental health providers? Absolutely. As you know, the crux of it is that the mental health system for everybody is in disarray and chaos, and there's not enough help to go around. And so sometimes it feels to families like you're looking for the unicorn. And so what I advise families is to find a therapist or counselor who at least has some openness to learning. Mm-hmm. So you may not be able to find a unicorn, but see if you can find yourself an interested horse. And by that, I mean that therapist who is going to listen to the family talk about how that person's autism affects them, what it looks like, talk to the person, maybe do some research on their own, and put in a little bit of legwork to take some of the burden off of the person with autism. Because right now, you're absolutely right, we do not have a slew of people that are out there saying, oh, I want, I really want to see patients who have autism and mental health and depression. Now, we do know that there are some practitioners right now who have autism and are practicing counselors, and we'd be more than happy to hook you up with them. We do know of, I could come up with 3 people, one of whose name I can't remember right now. But I'm more than willing to share those. We're willing to share the at Southern Regional Center too. But there are 3 people, right? 3 places that I trust right now, and I can add those to a resource sheet, and I'll get those to you, Josh. I'll get them to everybody. So y'all don't have to email me and ask them. I'll send them out to everybody who's on the call, as long as I have your email address. If you didn't register, you registered under a name that's different from your participant name, that means I have no idea who you are. And so I'm not going to be able to email you anything. So does that help, Josh?
Yes,
It's not a
thank
great
you.
answer,
And
but I'll do what I can do.
yeah, thank you. And my colleague Abby just put in the chat, she does not have a mic, but she's wondering if there are known protective factors for positive mental health outcomes for people with autism.
Number one, Josh, get Abby a mic. I mean, come on, you skinflints. Geez, give the poor person a mic.
Abby, come on over.
Sarah.
Yes, so I think that's an excellent question. I will say right off the bat, I don't know if there's specific research out there that's talking about protective factors specific to individuals with autism. Things that come to mind though would be, you know, the support system that person has, or, you know, past experiences in therapy and things like that can kind of bolster our responses to situations. So I think there certainly are, because we're not all, and again, autism or no autism, we're not all going to respond to the same situation in the same way, or the same experience in the same way. And so we might, you know, two people of course might experience one situation and have completely different mental health experiences following that. And there can be so many reasons for that. I think the number one thing that comes to mind though for me would be kind of the support system in place for that person.
Yeah, and I would, what comes to the top of my mind too is the ability to be in relationship. So the ability to trust someone, in that, you know, if we're looking for positive mental health outcomes, what we're doing is we're asking somebody to help us change. And that's hard. Not all of us are as open to change at different times in our lives. And so some of that goes back to that rigidity. But I think the lesson in my mind is, again, not the fact that somebody with autism can't. It just may have to look differently. And so they may not. So yes, being able to form relationships, good. Protective factor, okay. Doesn't seem to be able to, okay, can we help them? Maybe the first step of therapy is to help teach them how to form relationships and how to enter into a relationship. And then from that basis, we can then start to work on the mental health. And so it's taking into account that person's what they need, not just what I have to offer.
Absolutely. I think that, you know, that goes back to one of the points we were making earlier too, around, you know, potential modifications, adaptations, changes, what the therapy process may look like, or how that may look different for autistic individuals. And one could be that there is more time that needs to be spent in that initial, what we call like rapport building, or building that therapeutic working relationship together. And again, I think it's really important when working with autistic individuals to realize that just might be a part of the therapy process. And again, isn't necessarily a signal that they're not engaged, they don't really want to be here, that they're not really wanting the help, but that this is just a part of what this process needs to look like for them.
All right, any other questions? Either unmute or into the chat. I know we're coming up to the end of my normal 45 minutes, but I have been known to go 5 minutes over every so often. It's rare, but sometimes it does happen if we're having a good discussion. Sorry, Sarah, we weren't able to get to the differences between children, teens, and adults in depression, but hey, who knows? I might have an opening in October. We'll bring you back. I love talking about this intersection between mental health and disability. Is such a fascinating topic to me, and I believe very understudied. And I just think it needs people's boosted up. We just need a lot of help in this area.
Absolutely. I maybe I will leave everyone with one parting thought on that topic that we really didn't get into much. But one thing I always like to express or talk about is that one kind of big general difference at times between, again, kind of the prototypical idea of what depression is and what depression might look like in children or teens, spectrum or not on the spectrum, would be an increase in irritability or being expressed as anger or frustration rather than sadness. And I say the same thing when I'm talking about anxiety, that, we think about anxiety, we think about worrying, we think about being nervous, but a lot of times this may get expressed more as anger or irritability. So that's my big thing to be thinking about.
Right. So don't just write off that challenging behavior.
Yes.
Take the opportunity to look deeper and ask those questions. And again, what's out of the baseline? I really like that in analogy, Sarah, that, we have to know that person's baseline.
Yes.
Well, thank you so much for being here. Thank you, everybody, for joining us today. Really appreciate this conversation. If you have a moment, please give us a little bit of feedback so that we know whether we should be continuing these conversations or not. People are always wondering what the heck I do. And so if I can prove that I'm doing stuff that people enjoy, then I get to keep doing it. So please, but we really do want to know what sort of topics might be on your mind as well, so that we can bring in some of our friends and colleagues to talk to you. So Sarah, have a great rest of your day. Everybody else, I hope you have a great rest of your day as well. Thanks a lot.
Thanks, Tim.